Dementia, an issue too great to ignore. Dementia is a loss of memory and associated cognitive decline. The most common form of dementia is Alzheimer's, and most people who suffer from dementia are elderly. There are three main reasons dementia needs to be addressed, the first being the influx of cases. Lacey E. Hebert, who holds a doctorate in epidemiology from Harvard University, predicts there to be 959,000 new cases of dementia in America alone. This is due to America's high obesity rates and aging population. The second reason dementia needs to be addressed is the financial strain that it exerts on the American healthcare system. Christopher Cousett, who has a master's degree in English from Duquesne University, predicts that if nothing is done to address the cost of dementia by 2050, it could cost as much as $1.1 trillion in America alone. Most of this spending comes from Medicare, which is federal health insurance. Cousett found that Medicare spending for senior citizens suffering from dementia was 3 times higher than for senior citizens who do not suffer from dementia. Cousett also found that Medicaid spending, which provides health care to lower income families, was 19 times higher for senior citizens who suffer from dementia. The third reason dementia needs to be addressed is the poor quality of life for dementia patients. Abdullah Al-Fakri, senior researcher at the Joint Council of Extension Professionals, holds a master's degree in science from the University of Southern California, says that people who suffer from dementia become agitated or angry for small things that would not affect most ordinary people. This can be as simple as hunger, thirst, lack of sleep, or poor lighting, and this creates a poor quality of life for dementia patients. But what exactly causes dementia?
Although there are many theories regarding the origins of how dementia is formed, there are 2 main factors that have been shown to be consistent markers of dementia, as well as main possible causes of the disease. The first biomarker and possible cause of dementia is brain inflammation, which can have many underlying precursors. According to Maranthi Anna Kyortmazoglu, an associate professor of environmental health sciences at Columbia University, air pollution, which has a correlation towards dementia, can cause brain inflammation, hence these higher rates. Another cause of brain inflammation is obesity. According to Zainab Brehi, a member of the pharmaceutical department at the Institute of Technology and Science in Palestine, obesity can cause a glucose tolerance, leading to hyperglycemia. Hyperglycemia can cause brain inflammation, and the extensive correlation between obesity and dementia rates shows evidence as to why brain inflammation might be a possible cause of the disease. The second biomarker of dementia is the presence of misfolded amyloid beta and tau proteins. As explained by Francesca Buccellato, a researcher at the Institute for General Pathology and CNR Center for Research in Cell Pathology in Milan, Italy, misfolded amyloid beta and tau proteins that accumulate in the dementia brain are a distinct and universal sign of dementia. Both misfolded amyloid beta as well as tau proteins create clusters in the brain that directly damage the neurons of an individual experiencing dementia. So, now that we have a basic understanding of the plausible causes of dementia, what issues do we face regarding patient care for dementia patients?
There are 3 main problems with current dementia treatment plans, the first being the cost. According to Yizhong Huang, employee at the Department of Health Management at Sun Yat-sen University in Guangzhou, China, the global cost for dementia rose $214 billion from 2010 to 2015 alone. Much of this spending occurred in America, as Christopher Cousett says that nearly 1 in every 5 Medicare dollars was spent on somebody suffering from dementia. In 2050, it will be 1 in every 3. The second main issue with current dementia treatment plans is the non-ideal quality of care. Although there are trained professionals who can take care of people suffering from dementia, there is a lack of them, and the option is not realistic for most Americans, especially those with lower incomes. Renee L. Bergeron, associate professor at the University of New Hampshire, says that most caregivers are family members who receive no proper training. This lack of training results in a non-ideal quality of care because they cannot properly react to and treat the effects of dementia. The third and final issue with current dementia treatment plans is that there is no current cure for dementia. Dementia is not fully understood, and the drugs that could possibly be used to treat or even cure dementia in the future are not currently developed.
So, as we look at how dementia forms in the brain and the extenuating factors of patient care, cost, and more, how do we most optimally treat and prevent dementia? The first of our 2 solutions is drug therapy. And the second of our solutions that we proposed is exercise or physical activity. The first of the two solutions, drug therapy, focuses on reducing brain inflammation by ameliorating synaptic dysfunction. Rosiglitazone, a currently used diabetes medication, is shown to be a possible remedy for dementia by reducing overall brain inflammation. According to Michaela Nelson, a researcher with publications on the use of rosiglitazone in the treatment of dementia, rosiglitazone has been shown to reduce cognitive deficits in dementia mouse models. This shows a promising future for drug therapy avenues in the treatment of dementia.
The second solution we came up with is exercise. Susan Mayer, PhD in pharmacology and graduate from University College London and writer for the British Medical Journal, says if someone exercises for 115 minutes or more over 3 times a week, their chance of getting dementia is reduced by 40%. Mind, Mood, and Memory, a journal focused on late life memory loss, attributes this decreased risk to irisin, a protein released in the brain during exercise. Irisin has been shown to reduce neuroinflammation, one of the possible causes of dementia. Irisin is also hypothesized to be curative for this very same reason. Exercise is also combative against precursors of dementia like diabetes and obesity. The best part of this solution is the fact it can be added to current treatment plans at practically no cost. Both of these solutions have several limitations. Drug therapy has 2 main limitations. The first limitation drug therapy faces is the fact that it consistently fails human trials. Michaela Nelson says that rosiglitazone, a dementia-related drug, although proven to be beneficial during preclinical models, has failed human trials time and time again. Even if a drug was created that could treat dementia, the cost of creating said drug would be enormous. In 2002, Tufts Center for Drug Development said that the creation of a new drug cost upwards of $802 million. Drug therapy is also not preventative in nature due to the fact that dementia-related drugs cannot be taken as a supplement due to potential side effects. On the other hand, our second solution also faces limitations. Although exercise helps prevent dementia and is also possibly curative, it cannot be added to the treatment plan of those who have severe physical disabilities. This limitation is quite pronounced in cases of dementia since dementia patients tend to be elderly. Our best solution is exercise because it can be added to current treatment plans at practically no cost. Although people with severe physical disabilities cannot have exercise added to their treatment plan, the fact that exercise is both preventative and curative makes it the more ideal solution. Exercise should be added to all current treatment plans and pre-treatment measures. Oftentimes, the simplest solution is the best one.
I'm going to ask you some questions. Reese, give one specific way that your thinking changed as a result of learning about Grayson's findings.
Before I heard Grayson's findings, I thought that caregivers were always trained and they knew what to do when something happened, because they knew how to deal with people who suffer from dementia. But after reading from Abdullah Al-Fakri, which was one of Grayson's sources, and hearing that, it was Renee L. Bergeron, and that most caretakers are family members who receive no training, that sort of changed my thoughts, because I didn't know that the system for caretaking was so small and non-ideal.
Okay, good. Okay, Tony, reflecting on your colleagues' work, which one had the greatest impact on your overall understanding of the problem your group identified?
I would say that Reese's economic research really impacted how I thought about it because I was going off of a more scientific basis. And one of his sources, Christopher Cusat, went into the high costs for Medicaid and Medicare dollars, 1 to 5 in Medicare and 1 to 15 in Medicaid. So I didn't realize that the economic burden of dementia care was so intense, and that it had to be factored into as much when talking about the possible treatment plans.
Okay. And Grayson, if you had another team member, what other perspectives or limitations could they have researched that could have made a useful contribution to your project?
So some perspectives they could have explored are different types of dementia, like vascular dementia, and stuff like that. Another one would be like the non-linearity of how dementia progresses. I think that would also be really beneficial.
Okay, very good.